If you can raise your hand if you are able to hear me. All right, so let's start. The first station we have disc prolapse. Today we are going to discuss 12 stations. They are all recently asked by the GMC. So let's start. The first one is disc prolapse. Let's read the question first. You are after in A&E. Patient is 40-year-old male, has presented to the hospital complaining of back pain. Talk to him, assess and discuss the plan of management with the patient. The thing is, we have two stations before as well for the back pain. One was it's Mets, like it looks like a cancer. That was a previous station. One more they asked recently, that was a back sprain. And this is a third one. This is a third one, disc prolapse. Because when you elaborate this back pain, you will get a lot of points which will suggest that it's going towards intervertebral disc prolapse. Let's discuss first the differentials. What are the differentials for back pain? The first one is back sprain. Yes, this is back sprain, first one. Second is disc prolapse, cancer, Mets, osteoporosis, or trauma. So these are the differentials. All right. So as I already mentioned, this back sprain and this cancer Mets, we have these two stations before. Recently, they have added this disc prolapse one. All right. So when we elaborate the back pain history, it will be clear. It will be clear like if it is disc prolapse or it is back sprain. Okay. So the differentials are sprain, prolapse, Mets, osteoporosis, trauma. And if we know like roughly, for example, 4-5 differentials, that is more than enough. All right. The thing is, when you are elaborating this back pain, the thing is we need to ask some questions. In this station, patient is saying, I'm having this back pain for last 2 weeks, but since this morning, my pain gets worse. It's really bad, doctor. It's roughly like 8 out of 10. When we elaborate this, when we ask about tingling numbness, he's saying, yes, doctor. And he's giving this history like, yes, I'm having this tingling numbness and it is going till my big toe. So that is a point which suggests it might be disc prolapse. But the thing is, there are a lot of complications of disc prolapse. One of them is quada equina. So we need to ask these questions as well while we are taking history. So lower back pain, if it is there with bowel problem, for example, if patient is having constipation, for example, if patient is having urinary retention, or if patient is having sexual problem in the sense actually patient is like the male patient having impotence, but it will be like, it won't be easy for us to find out like impotence in just a 1 day history. And numbness in the saddle area, for example, like in the anal area, if there is a numbness. These are the points which suggest it might be quada equina. Quada equina is one of the complications of intravertebral disc prolapse. But make sure when you are doing this station, you have to ask question related to urine, question related to bowel problem, question related to anal tone, because the treatment will differ. If it is simple intravertebral disc prolapse, the treatment will be different. But if it is quada equina, the treatment will be different. They have asked this station twice actually, and both the times the history was a bit different. First time it was simple intravertebral disc prolapse, but the second time when they asked, it was quada equina because the patient was giving the history of urinary retention. In that case, it becomes an emergency. So we need to go accordingly. All right, and make sure. I know the patient is 40 years old, so make sure rule out the cancers and all. Ask about weight loss, loss of appetite. Even you can ask about this osteoarthritis and trauma to rule out other differentials as well. But do not forget this quada equina if you're suspecting this is intravertebral disc prolapse. All right. So let's see examination. Which examination you would prefer to do in this station? Definitely in all the station, what we are doing general physical examination, we are doing the vitals, we are doing local back examination, lower limb neurological examination, straight leg test. We have to mention about this straight leg test because if this test is positive, it's going more towards intravertebral disc prolapse. So definitely you have to mention about straight leg test. The thing is, in this station, when you're mentioning about the examination, like I would like to do examination, the examiner is asking, doctor, which examination you would like to do. Then you need to specify it. You need to specify, like, I would like to do general physical examination, I would like to check vitals, I would like to do back examination, I would like to do lower limb neurological examination, and straight leg test. He wants to hear every single examination separately. So you need to mention every single thing. All right. And in this station, he's giving straight leg test is positive. All right. And then you mentioned we will do some further investigations. For example, routine bloods you can mention, and X-ray you have to mention. Yeah. Now see the treatment. What will be the treatment in this case? The treatment of simple intravertebral disc prolapse is actually nothing much. It is symptomatic. If patient is having pain, so just give him painkiller, maybe paracetamol, diclofenac, or also we can give some muscle relaxant. Even for neuropathic pain, you can prescribe amitriptyline or gabapentin. All right. So that will be the symptomatic treatment. Secondly, if pain is not getting relieved, patient, you can offer physiotherapy to the patient. Even epidural injection you can mention. We usually don't do MRI straight away because in this country you will not get time. I mean, we will not get the appointment for MRI straight away if it is not an emergency. So if it is simple disc prolapse, MRI we do, but later after 6 weeks. Most probably the pain will be relieved, everything will be fine. But if pain is not getting relieved in 6 weeks, then we go for MRI. But as we mentioned, sometimes this station goes towards quada equina. If it is quada equina, patient is giving the history of urinary retention. As I mentioned, they gave in the previous previous scenario, the previous time, when they asked this station last time, they gave the history of urine retention. So in that case, it's going toward quada equina. So what you need to do is you need to admit this patient in the hospital. We need to catheterize this patient so that we can relieve his urinary retention and straight away go for MRI. Now we are not going to wait for MRI because we have to go for surgical decompression. You have to do neurosurgical referral and we have to go for decompression surgery. Why? Because quada equina can lead to irreversible neurological damage to the body, and we don't want that. We don't want any irreversible damage happening to our patients. So in that case, if you are suspecting it is quada equina, do MRI and neurosurgical referral. Because MRI, why we are doing? Because the cause might be something else as well. Cause might be something else. For example, the cause might be if there is any tumor sitting at in the spinal cord or something. So that might be the reason. Yeah. But in this case, in this particular scenario, the cause is actually patient is lifting heavy weight. He's working in a factory where he has to deal with the heavy weight stuff. So that is the reason actually in this patient for this disc prolapse. All right. So now what you need to remember is we have 3 stations for back pain. One is the cancer, the second one is back sprain, and this third one recently they started asking, this is disc prolapse. So in this patient is giving the history of numbness, tingling sensation, and giving the history of urine retention, and also giving the history that I'm working in a factory and I have to deal with the heavyweight stuff. So that kind of history you will get in this station. And make sure the treatment is symptomatic, physiotherapy, epidural injection might be, MRI after 6 weeks. But if it is quada equina, straight away go for MRI, neurosurgical referral for surgical decompression to prevent irreversible neurological damage. All right, so this was disc prolapse. Flu jab vaccination. This was also asked, like, I think couple of times recently in last 15 to 20 days. It's an easy station actually. There is nothing much in this station. Let's read the question. What was the question in this? You are in GP. You're active in GP. Patient is Luke, 3 years. Is due for the flu vaccination in 1 week. Mother wants to talk to a doctor. Talk to her and address her concern. Okay. Flu vaccination. The first thing is, who should be immunized? Who should be immunized? Those who are elderly. I mean, elderly people of 65 years, more than 65, they should be immunized. Pregnant women, we usually give this vaccination. Healthy children, like 2 to 8 years old, we give this flu vaccination just to prevent these kind of flu in these kind of patients. Yeah, if our child is not healthy, having some problems, so we might not give this flu jab because it is active. It's live vaccination. Because if a child is having any problem, life-threatening problem, any cancer or something, in that case we give other strain, we give inactive, we give killed vaccine, but this is live vaccination. All right. The side effect and contraindication of this medication, because in this station, the mother is having some concern. Mother is like, first of all, why we should give this flu vaccination. So we need to explain why we give, because we want to protect your child for having this flu. That's it. And she's like, doctor, I have heard that this there are a lot of side effects. It can cause seizure. It can cause this. It can cause that. So what's the explanation? The thing is, the side effects are mild. The side effects is fever. The side effects is rash, and seizure and encephalitis. The thing is, they are very, very, very rare side effects. And why the seizure happens? Actually, what happens is, after the patient has received this vaccination, patient might experience some fever. And because of this fever, patient might have febrile convulsion. So that is how you can explain it to the mother. Like, first of all, seizure is because of fever. So we can reduce the fever to protect the child. Yeah. So, but you need to give the possibility, yes, the fever is one of the complications, the rash is the seizure, and encephalitis. It's very, very rare, but this is one of the complications. All right. One thing that you have to make sure, because whenever you're giving any medication, or for example, here you are giving this flu jab, make sure if there is any allergy, because if patient had this vaccination before, and if he or she was allergic, so we cannot give this to the patient. We have to give some other vaccine. And one more thing, it was specifically mentioned, if patient is allergic to egg, please do not give this vaccine. We have some other strain actually we can give if the patient is allergic to eggs. And we have different flu jab we can give. So when you are asking questions, so make sure you ask this question if patient is allergic to egg or if patient is allergic to any vaccination. So these are the questions that patient is asking, the mother is asking. Mother is having only one concern actually, like if my patient, my child, my son will get any of the complication. That is the main concern by the mother. All right. Otherwise, it's a straightaway question. So in this, what you can do in the beginning, you can take a bit of history about the child as well. For example, how was the birth, any problem at all, how was the feeding, and if recently, if a child is having any fever, any cough, any flu-like symptoms, because if this is there, if there is a flu, if there is a fever at the moment, if the patient is having cough, so maybe we can wait for another week. When this fever, cough, everything subsides, then we can go for flu vaccination. All right. So all these things that we have to take in the history. All right. And then you need to address the patient's concern, whatever concern patient is having. And patient is having mainly concern about the side effect of this jab. Then you can address those things. Where can I get this flu jab? Actually, the patient is asking, and then where I can get this flu jab. So actually, it is available in the GP surgery and local pharmacy also. It is available. And if it is pregnant woman, it's midwife. You can get this from midwife as well. But in this, our patient is a child, 3 years old, and we are talking to mother. So if she's asking where I can get it, that's from GP surgery and also from the local pharmacy. Not all, but some of the local pharmacy, they give, you can get this flu jab. All right. So GP surgery, local pharmacy, midwife, if the patient is like pregnant women. All right, so this is actually very, very straightforward question. There's nothing much in this flu jab vaccination. So as you know, if any child, just take a pediatric history, ask about past medical illness, any allergies there like egg allergy or any vaccine allergy, and address the patient's concern, because the patient concern is about the contraindication or the side effects of this medication and where I can get this flu jab. All right, so these are the things. Next is this subconjunctival hemorrhage. See this picture as well. Something, this kind of picture you'll see in the exam as well. When you mention about the examination, examiner will give you some picture. And it looks something like that. Let's read the question. You are in A&E. Patient is a 75-year-old. Present to the hospital with complaint of red eye. Take history, discuss the management with the patient, and address the concern. The thing is, red eye, we do have one question, one station previously that was acute closure angle glaucoma. That patient, not this patient, that patient was taking amitriptyline, and which is actually one of the cause of glaucoma, and that patient is using the glasses as well. That kind of history, was there in that station. But this station is different. This station is completely different, but the question is almost the same. So when you see red eye, initially it used to be, oh, it's glaucoma, but now they have another station for red eye, that is subconjunctival hemorrhage. So red eye, let's see the so the differential. I mean, if it is the red eye, the differential is a stroma, foreign body, conjunctivitis, acute closure angle glaucoma, cluster headache, Ritter syndrome, inflammatory bowel disease. See, there are some, trauma, foreign body, yes, conjunctivitis, yes, glaucoma, yes, this subconjunctival hemorrhage, yes, cluster headache, yes. If patient is having headache, then patient is having something like red eye, even the watering from the eye you can see. Ritter syndrome and inflammatory bowel disease, so patient can have keratitis, patient can have uveitis, and all these are very, very, very important differential in this case. So we'll try to rule out as many as we can. But if it is subconjunctival hemorrhage, then what signs, symptoms, and what causes? Signs and symptoms are like a foreign body sensation. Patient will be feeling like, oh, there is some foreign body. Red eye, unilateral. Red eye will be unilateral, and what you will see flat, this bright red hemorrhage in the conjunctiva, like this, something like this. And usually it is unilateral. It is unilateral. So causes, there are a lot of causes that you can get. Actually, the history of any acute infection, for example, if you ask about if there is any fever, flu-like symptom, or if patient is coughing, even straining. So you can ask about, for example, the constipation and all, because patient is old in this case, 75. If patient is having constipation, he'll strain. That might be one of the reasons of getting this subconjunctival hemorrhage. History of coughing. If patient is coughing, so I mean, what do you need to do in this case? Ask about the recent health of the patient. Ask about the fever, flu-like symptom. Ask about the straining. Ask about the constipation. All these things will be really, really helpful. And don't miss red flags. If you have any red flags in or any station, please rule out. For example, in this case, if patient is using NSAIDs or if patient is on any anticoagulant, for example, warfarin or any anticoagulant, aspirin or warfarin, you need to ask, because that is again one of the cause of the subconjunctival hemorrhage. If patient is using contact lens, that is one of the reason. If patient is having any chronic condition, actually mainly is hypertension. Do not miss hypertension and heart disease. All right, so chronic condition, diabetes, hypertension, chronic heart disease, or high cholesterol. So these are the causes actually of a patient getting this subconjunctival hemorrhage. When you're taking this history, you might get a bit like in confusion, what it is. But when you will get that picture, then it will be very much clear in front of you. Okay, this is subconjunctival hemorrhage. So make sure we ask about these questions. Like history of coughing, ask about the recent health of the patient, ask about fever, flu, cough, and constipation, all those things. In the past medical history, ask about if patient is taking any medication, for example, NSAIDs, aspirin, or warfarin, patient is using any contact lens, or a patient is having any chronic medical condition like diabetes, hypertension, heart disease, or cholesterol. All these things are very, very important. All right. Differential, as we discussed, is trauma, foreign body, conjunctivitis, glaucoma, cluster headache, Ritter's, inflammatory bowel disease. For example, like in this case, uveitis, keratitis, everything. All right. Treatment. Treatment is actually, first of all, we do the examination. So in all the station we mentioned about, I would like to do general physical examination. I would like to check the vitals. So in the vitals specifically, as I mentioned in the previous slide as well, blood pressure is main thing. If patient is having high blood pressure, might lead to this hemorrhage. Yeah. So please definitely mention about this blood pressure. All right, and nothing much in the treatment here. It's a treatment of underlying cause. Underlying cause, for example, if patient is using contact lens, still don't use contact lens. If patient is using NSAIDs, don't use it. If patient is having coughing or straining, treat that. If patient is having Ritter, inflammatory bowel disease, anything, uveitis, keratitis, treat that. So treatment of the underlying cause is the treatment of subconjunctival hemorrhage. Otherwise, there is nothing specific here you have to mention. You can simply give some symptomatic treatment, because if patient is having any foreign body sensation, if patient is having like irritation in his or her eyes, so what we can offer artificial tears. Yeah. One thing now, in case of bilateral hemorrhage, if patient is having bilateral hemorrhage, patient is having hemorrhage in both the eyes, please refer the patient to ophthalmologist. But in our case, actually, in this one, this is unilateral actually. So there is no need to refer to the ophthalmologist, but you can give this as a warning sign. Sorry. You can give this as a warning sign, like if you see this kind of hemorrhage, if you see this kind of redness in both eyes, please do come back to the hospital. So if it is bilateral hemorrhage, we have to refer the patient to the ophthalmologist. But if it is unilateral, we can just tell the patient about these things, and I mean, it will be fine. And if patient is giving any history of any underlying disease, underlying cause, then definitely you have to treat it. And prognosis is really good actually in this case. Subconjunctival hemorrhage, prognosis is good. Yeah. And if patient is asking like how much time it's gonna take, it take actually few weeks, 2 to 4 weeks actually. Uh, uh, until this full redness will go. I mean, it might take 2 to 4 weeks, but like in Plab2, don't give the time frame. It's always better to say it will resolve in a few weeks. That's always the best answer. And yeah, sometimes this patient is asking how long it's going to take. So it's few weeks. It's roughly 2 to 4 weeks, and this redness will go. So examination, please do mention about this blood pressure, treat the underlying cause, artificial tears. If the patient is saying I'm having irritation, any foreign body sensation, that's the thing. And warning sign, definitely we're giving warning sign, follow up in all the stations. So tell the patient like if you have bilateral hemorrhage, if you have this redness, the same kind of redness in both the eyes, please do come back, because in that case we need to refer the patient to ophthalmologist. All right, and prognosis is excellent. Let's read the next one. Acne. They started asking this station acne, and they have asked actually 2 times now. So the question is, you are after in GP, patient is 24, a young lady, came to you in the clinic, she's having acne and wants isotretinoin medication for it. After the patient discuss the plan of management with the patient. So patient is having acne and patient wants this isotretinoin. And roughly, this was the picture in the exam. It was the forehead picture they have given in the exam. So in the history, first of all, what we need to do is we have to take history regarding those acne. What kind of acne it is? If there is any itching, if there is any discharge. I mean, what kind of discharge? If it is there, if it is a pussy discharge or a simple serum is coming out of the acne, and if it is painful. And if patient is using any cosmetic products, because these cosmetic products, they can make the acne worse. You need to take menstrual history, if there is any relation with the menstrual history. If patient is using any oral contraceptive pills, because if patient is using combined pill, that's actually good for the acne. So it's just better to take this history. Depression, why we are asking this history of depression? Because these patients, those are having this acne, they might go into depression, because patient is young female, 24, 25 years old, and having this acne, so that might affect her confidence. So please do mention about this depression. Ask the things about depression. Very, very, very important. So all these things, when you're elaborating about the acne, you need to ask itching, discharge, pain, usage of any cosmetic products, menstrual history, and COCP use, because it's good actually. COCP use, they are good in acne. And if patient is in depression, so please do ask, because it's very important. Now what we need to do is the treatment, because the concern that our patient is having in this case is what she wants isotretinoin. She wants that tablet. Can we give or not? That's the thing. First of all, being a GP, we are active in GP, we cannot prescribe tablet of isotretinoin. But yes, specialist GP, yes, they can prescribe, and dermatologists definitely they can prescribe, because there are a lot of side effects of this medication. And the thing is, it's topical and the tablet. Topical, yes, we can prescribe, but tablet, no, we cannot. We need to take a lot of things into consideration before we give tablets. Okay, so who can prescribe tablets? Specialist GP and the dermatologist. The specialist can prescribe. But yes, topical stuff can be prescribed. Yeah. So let's see. First of all, we need to know the grades of acne. So there's mild, there's moderate, one is severe, and actually they have given in a 4 grades. So mild is just like simply blackheads or whiteheads. That is actually the mild acne. Moderate is a multiple papule pustule and mostly confined to the face only. And if there is a large number of papule pustule, and if they are present on the other part of the body as well, for example, chest, back, that is moderately severe. And what will be severe if the large number of the large number of these painful pustules and nodules. So that will be severe acne. Because the treatment depends on that. Treatment depends on the grades of acne. So that's the thing. The treatment is this actually. Let's read this. If it is mild and moderate treatment is same. If you read the first line of treatment here, the first line of treatment, topical retinoids. Topical retinoids, yes, isotretinoin, but it is topical. Make sure it is topical. Or salicylic acid we can give with the topical antibiotics. Topical antibiotics includes erythromycin, clindamycin, or tetracycline. That is the treatment. If the mild acne, first of all, we discourage the single medication stuff. We give group of medication if patient presents to us with acne, group of medication, not the single one. So what we are giving here, we are giving topical retinoids with topical antibiotics. And you can give some adjunct as well. What are adjuncts? Adjuncts, they are, I mean, for example, if it's a pain station, for example, they are not the painkillers, but they will help in it. So, for example, here, this topical benzoyl peroxide, it is an adjunct. It will help in treatment of this acne. So, that is an adjunct we can give. So, if it is mild acne, we give topical retinoid plus topical antibiotics, plus or minus, maybe may not be this topical benzoyl peroxide. Yes, if patient is having side effect from this benzoyl peroxide, like irritation and maybe sometimes face become like really red and all, patient is having severe side effects, we can change this benzoyl peroxide to this topical azelaic acid. All right. The thing is, we don't need to know this much, but because the patient concern is only isotretinoin, she wants that tablet. And are we going to give it or not? That's the main concern. But still, we should know the treatment. The mild acne is topical retinoid plus topical antibiotics plus minus topical benzoyl peroxide. If the patient is having a side effect of it, we can change it to topical azelaic acid. Now, if it comes to moderate, that's the treatment is again the same. See, topical retinoid plus minus again the salicylic acid is antibiotic. It is oral. Here in the mild one, what we have topical antibiotics. Here what we have, it is oral antibiotics. If it is moderate acne, we give oral antibiotics with topical retinoids. Again, the adjuncts will remain the same. That is topical benzoyl peroxide. And if there are side effects, then up again it is topical azelaic acid. Yeah. So mild and moderate, almost the same. There's nothing much change here. Fine. Even for the severe one, what we do, first we start with again the topical retinoids plus oral antibiotics. And adjunct will remain the same again, topical benzoyl peroxide. If there are side effects, topical azelaic acid. It is the same, but if patient is having severe and this treatment of moderate that we are giving, it's not helping, then we take specialist review and then we prescribe this oral retinoid. That is isotretinoin. So in severe one, also, first of all, we start with topical treatment. We start with topical retinoid. We start with oral antibiotics. We start with topical benzoyl peroxide. That's an adjunct. If patient is not feeling better with this, then we go for this oral retinoid. So if you get this station, ask this patient what you are already using, what you have already used for your acne. So if she's saying, yes, doctor, I have tried this topical retinoid, I have tried these oral antibiotics, I have tried everything, still I'm having this problem, then definitely you can refer this patient to specialist, and specialist might consider giving this oral retinoid. Yes, but the picture that we have actually, it looks like it's a moderate one, not the severe one. So what we'll go for topical retinoid, we'll go for topical retinoid, not the oral one. So topical retinoid plus oral antibiotics and adjunct. That is what we need to do. But patient is asking only one thing, that is isotretinoin, so that we are not going to give straight away. Yeah, that is for severe acne, and it is usually prescribed by the specialist dermatologist or a specialist GP. And it's not the first line treatment, it's the last treatment. First we go for topical retinoid. All right, so that's the main thing. And there are some misconceptions about the acne. It was written on the NHS website. Let me read it for you. I mean, the thing is, acne is caused by dirty skin and poor hygiene. That's a myth. I know a lot of us must be thinking like, if the hygiene is not good and dirty skin, that might lead to acne. No, that is a myth. Second is like squeezing blackheads, whiteheads, and the sports is the best way to get rid of acne. No, it is not. So if they're blackhead and all, go for the treatment. Don't remove them. Second, a lot of people think like if you are having a poor diet, that is gonna make acne worse. No, that is a myth. That is a misconception. Next is a lot of patient they think like if they're having frequent sex and masturbation, that's gonna make their acne better or worse. No, that's a myth. It's not gonna affect anything. Doesn't make any difference. All right, and acne is infectious. No, it is not. So there are some misconceptions that all of us we have actually. So diet is not related to our acne. Dirty skin, poor hygiene, that's not related to acne. Acne is not infectious, and having sex or masturbation is not going to make acne worse or better. So these are some myths that we have. So if patient is having any of the question, you can simply say they are myth. They are nothing related to acne. All right. So that was acne station. Mainly the patient concern is isotretinoin. So if we are going to give it to her or not. So at the first thing, we don't give. That's the thing. All right. So the next one, tiredness. Tiredness, citalopram. All right, let's read the question. What is this? You're after in a GP. Patient is 50, has come to the clinic with a complaint of tiredness. She was diagnosed with the depression, and patient is taking citalopram. And the GFR of the patient is more than 60 ml per minute. Take history, discuss the management plan. So patient is having tiredness. Patient is 50, and the GFR is more than 60, and patient is taking this citalopram. So a lot of information they have mentioned in the question. So first of all, tiredness. So you should have at least like 5-10 dBs in your mind. Tiredness. Patient is 50. Patient is old. Patient is having tiredness. So what do you think we should go for? In differential. First is cancer. Yes, definitely you should go for cancer. So ask about weight loss, loss of appetite, and dizziness, shortness of breath, palpitation. Yeah, all these things you need to ask. Cancer. Hyperthyroid. Yes, hyper. It should not be hyper. It is hypothyroid actually. Tiredness. So tiredness actually it should be hypothyroid. So hypothyroid can have a tiredness. So ask about again weight loss and all, because hypothyroid patient will be having weight gain. So instead of asking weight loss, weight gain, both the question, ask about any weight change. So by asking one question, actually you can rule out cancer also. You can rule out hypothyroid as well. Yeah. Anemia. Again, anemia is one of the very important differential because the patient is old, 50 years. So yes, definitely. So anemia, what question we can ask? Like you can ask tiredness, you can ask about palpitation, dizziness, all these things you can ask to rule out anemia. IBD, yes, why IBD? Because these patients, IBD patient might have this diarrhea, patient might have blood in the stools. So that is why the patient might have anemia because of that, and that's one of the reasons. CKD, why CKD? CKD patient will be having swelling in the leg. This is how you can ask. But why CKD patient? Usually these CKD patients, they are having anemia. They are anemic usually. Drug induced, yes, SSRI and all those things. Yes, SSRI. This is citalopram, antipsychotics, everything. I mean, they are one of the reasons for tiredness. Why? That we will discuss. And depression, yes, if patient is having depression, so they might be tired. Because in this country, make sure these kind of station do ask about mood and all, do ask about depression. A lot of things are related to it. They want us to take a bit general kind of history, a generalized history. So do not miss this kind of stuff. So tiredness has got lot of things like cancer, hypothyroid, anemia, IBD, CKD, drug induced, and depression. Yeah. So let's see next one. Now we have to do the examination. Actually, we will, as we have mentioned in previous station, here also you need to mention like I would like to check your general physical examination. I would like to check vitals. We'll check chest, heart, and then we'll be doing some routine investigation. Routine investigation include full blood count. It includes the blood sugar, because blood sugar is also one of the reasons for tiredness. If patient is having diabetes, so that these kind of patients also feel tired, so rule out that as well. Do an ECG, UNEs, TFT, thyroid function test. All these things you have to mention. Yeah. So as you know, like sometimes examiner might give you some finding, not always. Sometimes he might give you some finding. For example, in this case, examiner is giving this finding: sodium is 128, Normal is, as we know, it's 135 to 145 millimole per liter. Potassium is 4.8. The normal is 3.5 to 5. Urea is 4.2. It's actually normal range. EGFR is more than 60. EGFR more than 60. It's also mentioned in the question as well. Yeah. So this is the stuff we have. So in all the history station, make a habit that you need to mention about the examination. You need to mention about the investigations. All right. Because sometimes they will give you some findings. For example, in this station, they will give you these findings. They will give you sodium. They will give you potassium. They will give you urea and EGFR. So now, what's the problem? Why a patient is having tiredness? The cause of tiredness might be this hyponatremia. You know, if patient is taking this antipsychotics, this citalopram, it can lead to hyponatremia. It can lead to hyponatremia. So that might be one of the reason here, because this patient is giving the history of tiredness for last 2-3 weeks since this medication was started. Medication was started like 3 weeks ago, and patient started feeling tired like from last 2 weeks. So it's not a very long history. So these kinds like cancer and all other things are a bit unlikely, but these are red flags. So we are gonna cover it. We're not going to miss those things. We are definitely going to cover those things. But this this antipsychotic, this citalopram can cause this hyponatremia. Yeah. So that is one of the reasons. And also make sure potassium. See, potassium is 4.8 here. Citalopram causing hyponatremia. The cause might be SIADH. I'm saying the cause might be SIADH. But only on the basis of these investigations finding, the investigation finding we have at the moment, we cannot make a diagnosis of SIADH. But if patient is taking citalopram, patient is having hyponatremia, the most probable cause is SIADH. But in this station, make sure it's not like you have to say it is SIADH. The thing is, you know, hyponatremia, why patient is hyponatremia? It's because of the medication. So what you have to say is, we will refer you to a specialist, maybe psychiatrist or maybe to a specialist. They will change your medication because this citalopram might be the reason of your hyponatremia. Yeah. But what I'm saying, like, if you feel like they want to know about more, they want to know more in detail, you can say that it might be because of one of the condition, and we need to do some further investigation. What further investigation will do? We have to do urine serum osmolality and all. Only on the basis of that thing we can tell if it is SIADH or not. But yes, citalopram can cause hyponatremia. The most probable cause is SIADH. So let's see. I mean, if they'll ask second, third time, let's see what they want. But the candidates, those who appeared actually for this station, they were saying like a patient was really satisfied when they said like it is because of citalopram, and that's why patient was having this hyponatremia. That's why you're having tiredness. So we'll refer to a specialist. They will consider changing your medication, and you will be fine. Because it's 128, it's not that much severe. If it is less than 125 or something, then it is a bit severe. Otherwise, it's not that severe, but yes, patient might have tiredness because of it. And make sure, see this potassium as well. Potassium is 4.8 here. For example, if potassium is high, for example, do ask about any skin problems and all as well, because it might be Addison disease as well. So we need to cover that as well if potassium is high. But usually, in this case, they are giving potassium in the normal range, But still, when you're taking the history, you can ask about some skin problem as well, skin lesions, skin problems. Okay, so in this station, what you need to do in the management, actually, it is tiredness is because of this medication. This medication is causing this hyponatremia. You are losing salt from your body. That is one of the reasons. So we can just refer you to the specialist, and they'll consider changing your medications. That will be the management here. All right, and I said it might be because of SIADH. The most probable cause is SIADH. Now let's just have a look at this stages of chronic kidney disease. The normal eGFR, because in this station they mentioned the GFR was more than 60. So let's see in which stage this patient is. Stage 1, if the eGFR shows normal kidney function, GFR normal kidney function, but you are already known to have some kidney damage. The eGFR is not the only criteria to stage this chronic kidney disease. It has got some other criteria as well. For example, here, if eGFR is normal, but patient is having any known kidney damage or kidney disease. For example, you may have some protein blood in the urine, or maybe any kidney inflammation, anything at all. So that is stage 1. And irrespective of EGFR, patient might have some problem in the kidney. The patient having EGFR that is normal, that 90 or more than that, but still patient might be in the stage 1 chronic kidney disease. Yeah. Stage 2, the mildly reduced kidney function, like 60 to 89. That is our patient here. Our patient is having EGFR more than 60. So stage 2 is mildly reduced kidney function, and you are already known to have some kidney damage or disease. People with an EGFR of this without any known kidney damage or disease are not considered to have chronic kidney disease. So it's just a stage 2. EGFR is more than 60 but less than 90, and they have some underlying kidney damage. Stage 3, they have got like 3 points: 3A, 3B. 3A is 45 to 59. 3B is 30 to 44. Yeah, so moderately reduced. It's like with or without a known kidney disease. For example, elderly patient with aging kidney may have reduced kidney function without a specific known kidney disease. If a patient is young, the EGFR is 90 more than that. But if patient is aging, patient is getting older, the EGFR will reduce. When the EGFR will be less in that patient. Yeah, and the stage 4 is 15 to 29. EGFR will be 15 to 29. So again, it's a severely reduced kidney function with or without kidney disease. And less than 15, it is very severely reduced kidney function. It is actually end stage kidney failure. Yeah. So there are stages. It's like if you just want to have an idea, because if you know the numbers, we can easily remember it. More than 90, stage 1. If underlying cause is there, and if there is any underlying kidney damage. If it is 60 to 89, that is stage 2. If it is 30 to 59, that is stage 3. But in this, they have given 3A, 3B. So it's 45 to 59A, is 3A, it's 30 to 44, is 3B. Then stage 4 is 15 to 29, and stage 5 is less than 15. So this is how we can stage this chronic kidney disease. All right. So this was a chart. Actually, you can have a look. The thing is, you can download this these PPTs from the handouts. You can see the option. You can download it, and later on you can see all these PPT. You can revise it, because I know your exams are near, so it's easy to go through if you have the PPTs with you. So you can download these PPTs from the handouts. I put it in the handouts. So in this one, what you can see is, as I said, the hyponatremia. In this case, patient is taking citalopram. Patient can have hyponatremia because of that, and the reason is most probably SIADH. So SIADH, we cannot just diagnose SIADH like that. How we can diagnose is we have to do further investigation. We have to do osmolality, plasma osmolality, urine osmolality. Only on the basis of that we can say this. Yeah. If it is SIADH, the treatment is usually fluid restriction, and we give some medication like Vaptans or demeclocycline. But the thing is, that will be too much for the patient to handle actually. But for our knowledge, we should know. So all these things we have kept in this chart. It is like if it is patient is in hypervolemia or hypovolemia or euvolemia. So all the things are here. Yeah. So accordingly, we can find out what exactly going on with this patient. But this patient looks like is an SADH. Yeah. But our treatment for our exam is like, it's because of citalopram, so we will change your medication. That's it. Nothing much we have to do in this case. Okay. Let's move to the next one. Delayed discharge. Recently, they started asking this station as well. Delayed discharge. It's actually a very similar station that we have done previously. If you remember, we have one station. We are talking to a doctor, Dr. Wilson. He or she forgot to change the cannula, and the patient was angry. So same here, same kind of story. Here, what is happening is the patient is angry because patient was supposed to be discharged, but there has been a delay. There might be some reason why there is a delay. So that's the station. So in this station, we are talking to our colleague. So this station will go the same way as we have discussed the Wilson station. Talk to Dr. Wilson. First of all, we should know how to talk to our colleague. First of all, let's read the question. What's the question? You are up to in acute medicine. Dr. Gupta is an FY1 working in your department. Mrs. Stream, that patient was Mrs. Reaver in that Dr. Wilson station. So here it is his Mrs. Stream. Mrs. Stream is about to be discharged, and Dr. Gupta has to write the discharge notes and he has to discharge the patient. She asked Dr. Gupta 2-3 times to get discharge typed up. He didn't do that, and now she wants to make a complaint. Okay. She asked the nurse colleague to contact the doctor. The ward manager also came to the ward saying that the beds are not empty and the patient are waiting in the A&E to get the bed. Because if this patient is there in the ward, then a lot of patients are waiting in the A&E because ward manager, it's their duty. They have to manage the beds and all. A lot of patients are waiting in the A&E, and the patient who was supposed to be discharged is still in the hospital. So that's a big headache for the ward manager as well. So ward manager came to the ward saying that the beds are not empty and the patient are waiting in the A&E to get the bed. Okay. So what we have to do in this station, talk to Dr. Gupta and manage the situation. All right. And they have given a special note. Special note is actually there to help us. So what is special note here? The FY1 is sick. The F1 is sick and is on leave. So from the question itself, we get a lot of ideas. The idea is like one F1 is sick. So what might be the reason in this case? The reason might be that that other FY1 is on sick leave and Dr. Gupta is the only doctor working in the hospital. Working on that ward. So that might be the reason, because the Dr. Gupta is doing a lot of work, is overburdened, and that's why he couldn't make the discharge summary of the patient. So that might be one of the reasons. I'm just saying like that might be the thing you will be having in your mind before you enter into the station. Yeah. All right. So let's see how we have to do the station. So how we do this station actually, I will not take much of time in this station because this is a bit of old station, I would say. The similar kind of station. So first of all, whenever you're talking to your colleague, please make sure you make a rapport with your colleague. How are you? How's everything? How's posting going on? Any problem at all? All these questions, please do give the importance. Just make that rapport with your colleague. That is the first thing. And then you will try to find out the stuff. Recognize their anger. It's like for the patient. I'm trying to cover both the things. If you're talking to patient, if you're talking to the doctor in that case. So first, in this case, what you're supposed to do is, what we are doing is make the rapport. That's the first thing. And then we will slowly will disclose what happened actually. So you need to tell about that Mrs. Stream. So Dr. Gupta, do you know about our patient Mrs. Stream? Yes, I know. I was supposed to make her discharge. So were you able to make the discharge? No, doctor. Actually, I was busy in the ward. One of the doctor was sick, and I'm the only one working in the ward. So it wasn't. I was not able to make the discharge that time, but I'll make it soon. Then you need to tell her, because the patient is angry, and you could have mentioned it to another colleague as well. They might help you, or you could have talked to your educational supervisor. They might have helped you. They might have provided you with one of the colleague, isn't it? One of the other colleague from the other ward might have come to you, and he or she might have helped you for some time. So that kind of stuff, that kind of solution you can give. And in these cases, definitely you need to give the solution. So what is the solution? Solution is like you could have talked to someone. You could have talked to me maybe. You could have talked to your education supervisor. You could have talked to HR department. Like I'm the only one here and a lot of patients are here and one of the FY1 is sick. So I need some support. But maybe because Dr. Gupta, he is FY1. He recently joined. So that these kind of things, maybe he doesn't know. So these things we just have to tell him. But make sure don't accuse him. The thing is, Dr. Gupta, he didn't make any mistake. It's just he was overburdened, and he didn't have much idea about the hospital protocols. That's the only thing. Okay. So tell Dr. Gupta that Mrs. Stream is angry. So it's better if you just go and apologize to her and just change and just make the discharge summary. That's it. This is what you need to do. But before you end the station, make sure you mention about the incident form. When you mention about incident form, of course, the patient will be a bit worried, oh, incident form, why incident form? Doctor, I didn't make any mistake. We just have to tell, I know it's not a mistake. It's just a hospital protocol that we have to fill this form so that we can prevent this kind of incident happening in the future. As you mentioned that one of the FY1 is sick. So in this case, if we will fill this incident form, so our HR department, NHS, everyone will be they will be knowing if one FY1 is sick, so they might give that job for that particular day to someone else. Maybe they disappoint some local workers or something like that. So we'll not be having these kind of situation later in the future. Yeah. So do mention about incident form, and do mention about your senior that I have to inform, that we have to inform the seniors as well. Why we need to inform the seniors? Because all these incidents, whatever happening, we should inform the seniors or education supervisors. So please do mention about that as well. But mention it everything in a very subtle way. You should not sound like you are just making a complaint against Dr. Gupta. So don't do that. Don't do like that. Just make it in a very subtle way. Even you can say like, it's better, Dr. Gupta, if you can inform your senior. Because we are not saying that I will inform the senior. I'm saying if you can inform your senior. The thing is, our ultimate aim is to inform senior. Doesn't matter if I'm informing or you are informing. So mention all these things in a very subtle way. Don't like we are just making complaint. We should not sound like that. Yeah. And also mention to Dr. Gupta as well. Dr. Gupta, so do you have any idea if patient wants to make a complaint, what you should do? And if he knows about it, it's fine. If he doesn't know, then you need to mention about the pulse as well. Like Dr. Gupta, as we have a office here in the hospital, patient advised and liaison service, so patient can make a complaint there. So it's the same thing, same question as we did previously, with the Dr. Wilson. So it's Dr. Gupta here, and it's almost the same stuff. The one thing is here a bit they have added is the ward manager came to the ward saying the beds are not empty. So please do mention that thing in the station. Like Dr. Gupta, as you know, that the ward manager was also looking for the beds, and as Mrs. Stream, we haven't made the discharge for Mrs. Stream, so she's in the hospital at the moment, and a lot of patients there waiting in the A&E as well. So ward manager is also a bit confused or a bit worried about all these things. So do mention this thing also in the station. Otherwise, it's the same station. There's nothing different. All right. The next one, DNR. This is again an old station. Actually, we had this station before as well. So I'll go very quickly with this station as well. Initially, we used to have the station where the patient doesn't want to take the heart medication because the patient had heart failure, heart attack. But this patient is a bit different. Let's read the station, then we will be able to find out what's the difference. You are in oncology, you are active in oncology. Patient is Arthur, age 75, has presented to the hospital with chest infection yesterday. The consultant advised to take IV antibiotics. The treatment is going well, and the consultant is happy with the results. All right. Patient was receiving chemotherapy for the last 3 years for lung cancer. Patient had lung cancer, and patient was receiving chemotherapy for that. It's a small cell lung carcinoma. Please talk to the patient, explore the patient thoughts, and assess whether the patient knows the implication of his decisions or not. So actually, it's a similar kind of station. It is a similar kind of station that we have done actually. That same DNAR station that we discussed like previously as well in ethical station. It's the same again. So first of all, he's saying what is the reason actually. The question is explore the patient thoughts. I'll tell you what are the patient thoughts actually. Patient is like, I don't want to take any medication. Patient is saying, whenever I'm taking these chemotherapy, I'm getting this infection. I have to come to the hospital and they're admitting me here and giving me these antibiotics. I'm fed up of my life. I have lived enough. I'm 75 and I don't want to continue with these medications. I want to take I don't want to take chemotherapy. So if I'll not take chemotherapy, I will not get any infection. I don't have to come to the hospital and I don't have any regrets in my life. So that kind of story this patient is telling. Yeah. So what we need to do here is we need to find out the reason actually why you don't want to take the medication. What's the reason? So he will tell the chemotherapy. The reason is, doctor, this chemotherapy, whenever I'm taking chemotherapy, I'm getting this infection, I'm getting this chest infection, and because of that, I had to come to the hospital again and again. Yeah. So that is the reason. So we need to find out the reason first. Now understand retention. That is very, very, very important thing. See, patient is saying, I don't want to take the medication, but we have to make sure if patient is understanding that thing or not. If patient is understanding, if patient knows what will happen, if patient knows what is the function of chemotherapy, why we are giving you this chemotherapy, if you will not take this chemotherapy, do you know what will happen? So everything like understanding whether patient understand what kind of treatment we are giving, whether patient is able to retain that information. And the third is implication. Implication means if you will not take this chemotherapy, do you know what will happen? If patient understands everything, if patient can retain that thing, if patient knows the implication of his decision, then yes, we cannot do anything for that patient, but still we'll try to convince the patient as we are happy, because in the question it is mentioned that the consultants, they're happy with the treatment that patient is receiving. So patient was improving whenever he's admitting this patient was improving. So find out the reason why, understanding, retention of the information, implication, if he's understanding or not. And try to, in these kind of situation, what you need to do is try to take a very good social history. Because this patient, when he's talking, he sounds a bit like frustrated. So ask, whom do you live? If he's living alone or living with the family. What is happening actually in this case? He's saying, I'm living alone. I don't have anyone. My wife died. My old friends died. I used to have one daughter. One daughter who is having some problem with the joints. She's having rheumatoid arthritis. Maybe once in a while she's coming here. Not always. So, but I'm always like, feeling alone. That kind of history actually he is giving. So you need to take that history in detail about this social history. I mean, and after that, try to convince him. See, try to convince him. Please do not force the patient. Patient can take his decision. Patient can make his or her own decisions. But being a doctor, we can convince the patient if you feel like patient is not doing the thing that is right. If you feel like, so what you can do, you can convince the patient. Yeah, so we'll convince the patient. So if you feel like that patient is sounding like that he's living alone, so what options you can give? You can give the option of Age UK. This is actually a voluntary organization that we have in UK. What they do is there are some volunteers. They can go to their house. As in this station, patient is saying, I'm living alone. So actually, that is one of the solution of this living alone stuff. Living alone stuff, I mean, so these volunteers actually, they can go to their house for maybe once in a week, and they can have a chat with them. Maybe they can play some crosswords or any other game, and even if they want, they can go out maybe for a cup of coffee, all these kind of things. So UK actually, there are some registered organization, there are volunteer organization by the name this Age UK. So they voluntarily help people, old age people, if they feel lonely, this kind of stuff. So you can give him option. You have to give him option. Doesn't matter if he's accepting your options or not, but being a doctor, just give them option, as many options you can do. Even if you feel like, you can mention about occupational therapist as well, because this patient is having some problem with the chest infection. So maybe in the house, when the patient is having this chest infection, because patient have this lung carcinoma, so maybe patient is struggling in the house, maybe going upstairs, coming down, all those things making this tough for the patient. So we can give him option, like if you feel like we can make some changes at your home conditions. So we can tell our colleague, occupational therapist, they can go to your house, they can visit your house, and if needed any changes need to be made, so that could have been better. Yeah. So we have to convince the patient. That's it. If you're not able to convince him, then don't worry about it. Don't worry about it if you're not able to convince. Because it depends on that day, how the examiner, they have trained the simulator. If he's not getting convinced, that's also fine. If he's getting convinced, that's also fine. So convince the patient to view their decision. Like, don't you think like if you will do this, it would be better? So something like this kind of stuff you can use. Yeah. And it's always better, because this patient is having this trouble, chest infection, for a long time. Please do mention about the mood, the depression part of the story. Maybe patient is depressed at the moment, and that's why he just want to make this decision. So in all these things, please make sure patient is not depressed. So ask about the mood and all those things. Mood, how's your mood? Can you please score your mood? So all these things will help you in making sure that patient is making this decision in sound mind. Yeah. And also sometimes this patient, because the question says assess whether he knows the implication of his decision. His one decision is, I don't want to take this chemotherapy, I don't want to take this medication. Sometimes, because this patient talks a lot, and our station, our 8-minute will finish here only, but sometimes what happens is patient will go further, a bit more further. He will ask about, he will tell you about this, what do you say, the form. Doctor, I want to sign that form as well. Which form? The DNA form. Like, if my heart stops beating, I don't want any one of you do this CPR. So yeah, so again the same thing, like you have to mention, so do you know what is CPR? Do you know what will happen if you not do this CPR? Have you discussed it with your daughter? Always when patients, they're making this kind of big decisions, so please do tell them, like, have you discussed it with any one of your family member or friends? For example, in this case, you can mention about, have you discussed it with your daughter? Because patient is saying, I'm having a daughter. So you can mention that thing. Yeah, so it will be very, very helpful. So I'm saying all the time this station is not going for DNAR, but yes, a lot of times, yes, it is going. Because this patient talks a lot, and usually the 8 minute will finish when you are talking only about this medication. Don't want to take this medication. So you're just trying to convince them for the medication, and time will finish. If not, patient will start talking about the DNAR part of it. But again, it's not compulsory that patient will always talk about it. Patient may. Yeah, fine. So it's an old station, it's the same station, but they just made small changes. So don't worry about it. Yeah, let's go for another one, the new one. Fungal infection. And see this picture carefully, because it's almost the same picture they showed in the exam as well. Something like this. Yeah, so let's read the question. Very easy station. So you are actually in GP clinic, a 45-year-old male has come to you with some concern, talk to him and address concern. So actually they haven't mentioned much in the the question, like what's the problem. They just mentioned came to you with some concern. All right, so what kind of concern our patient is having, that we have to find out actually. So first of all, this kind of skin lesion, what can be the differential? It looks like a fungal infection. It might be Lyme's disease, might be the rash of meningitis, might be eczema, might be psoriasis, or maybe sarcoidosis also, might be IBD, because IBD also have some skin lesion, cancer, maybe it's a skin cancer, but doesn't look like that, but okay, it's one of the differential. So the thing is, the first picture, in this you can see two pictures. Yeah, so this is actually fungal infection. That was the previous picture as well I showed you. What is this? This is a bit different picture. Initially actually we were confused whether they gave this picture or that picture, but yes, we have confirmed this picture they gave actually in the exam. This is actually Lyme's disease. This picture is Lyme's disease picture, bullseye, if you can see. Yeah, and this is just only the ring. Yeah, so that is fungal infection. So this is how you can differentiate actually. You will see some redness in the center as well, which is Lyme's disease. But if it is just a round ring, that is actually a fungal infection. In the exam, they gave this fungal infection. So these are differential. It's always good if you will rule out these differential. What kind of history do you think you should take? So first of all, ask like how long you're having this problem, and what do you think this lesion, is it increasing in size or is it the same? Is it getting worse? Do you have any itching? Do you have any pain? Do you have any discharge from this lesion? So all these things, do you feel like that if it is itching, it's itching in the morning, in the evening time, or what kind of climate, has it happened before? All this history you need to take. All this history you need to take. You need to elaborate this infection, this lesion very nicely. And yeah, and try to rule out all these things as well. Ask about the recent health of the patient. Try to rule out meningitis. Yeah, because patient is 45. I know it's a bit unlikely, maybe meningitis, but still ask about any fever, flu-like symptom. Yeah, and ask about eczema. Also, you can ask any previous history of any skin disease. Yeah, and also you can ask about cancer symptom, maybe 1 or 2 lots of hepatitis, weight, and all. The skin cancer also, but yeah, it doesn't look like, because by looking at it, it looks like fungal infection. But the thing is, they will not show you the picture in the beginning of the station. Yeah? They will show you the picture in the mid. Once you have taken the history, once you want to examine the patient, they will give you the picture that time. So before that, we don't know what kind of lesion it is. We need to make sure we rule out other stuff as well. Yeah. So for Lyme disease, ask about like if there is any insect bite or any insect bite or something like that. That we need to rule out. Yeah, so all these things we have to ask, because patient is telling that it's just a round lesion I have. So round lesion, what it can be fungal infection, can be Lyme's disease, can be anything. I mean, so when you're taking history, try to rule out some of the differential. Make sure you're ruling out some life-threatening or red flags. Every station, make sure rule out red flag. Yeah. Okay. So what are the risk factor actually in these kind of scenarios? Risk factor is actually if it is like warm, humid climate, there are more chances of getting fungal infection. Yeah, contact sport. If patient is playing contact sport, what are contact sport like football? Football was going on. So football or rugby, all these kind of sport, if patient is playing, so that is again a risk factor of developing a fungal infection. or immunosuppressant, I mean immunocompromised patients, like if patient is having diabetes or patient is taking an immunosuppressants, an immunosuppressant like methotrexate or anything, or maybe any steroid for a longer time for anything. So these are the things that you need to ask in the history. For example, ask about contact sports. So ask what's the profession. Ask about in the past medical history if you have any past medical history like diabetes. If you are taking any steroid or something, that you can ask in past medical history. Yeah. So all these things you need to ask in the history. All right, so what's the treatment of fungal infection? It's a simple, give antifungal. There's nothing much that you have to do here. So the treatment is simple antifungal that is available like as a cream, as a gel, as a spray, and some oral antifungals can also be prescribed. But like oral antifungal can be given by the specialist. So initially we just give the cream or gel or the spray, not the oral antifungal. But maybe if it's required later on, the specialist can prescribe oral antifungals as well. But in this kind of scenario, please do mention about the general advices. This is very, 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 very important. Tell the patient like like keep your clothes, your towels and bed sheets separate. Very important. Sorry. keep your skin clean. That is again a thing, and avoid contact with the people or the pets with the same problem. So, like in this country, people are, they're fond of pets. They're having pets at home. So ask like if your pets has got the same problem, they're having the same skin problem or any skin problem actually. So avoid contact with the people having the same problem or people having any skin problem at the moment, and the pets with the same problem. Yeah. So some general advice is always better to give some general advices. Yeah. So that was fungal infection, very important. So make sure the lesion, what kind of lesion you'll get in the exam. This is the lesion that they are giving in the exam. This one, fungal infection. This is Lyme's disease with central redness. This is bullseye. Fine. Let's go for the next station. Easy one. Drug prescription. Actually, this station was very easy station. In this station, they have mentioned a lot of medication in the task itself, and we just have to explain those medication to the patient. Very easy task. I just want to tell a bit of things in this station. This was a question, actually, it's a very big question, actually. You are after in surgery, a 64-year-old female was admitted in the ward with pelvic fracture and was diagnosed with osteoporosis. She developed urosepsis while she was the treatment, and which was managed with antibiotics. She is now being discharged and wants to know about the medication that have been prescribed to her. Talk to her and prescribe these medication, address her concern. A very, very, very simple question. And these medication were also actually there in the question. And also you will get these the name of these medication outside inside as well. So amoxiclav, if medication is given in the exam. So the thing is, amoxiclav, some candidate were saying it was BD, some saying it's TDS. Actually, doesn't make any difference. You need to explain it. Whatever it was there, you just explain in the same way. Codeine, 1 tablet. PRN, what is PRN? It's pyrorenata. That means if necessary. Then alendronate, 70 mg main. What is main? MANE. I'll explain what is main. Calcitriol, that is a vitamin D medication. So patient was supposed to take BD. Lisinopril, 5 mg OD. And previously it was like 10 mg, but it was changed to 5 mg. All right. ECM, 2 tablets. PRN or BD, and atorvastatin 10 mg OD, and there was one more Lexido sachet PRN. It was actually it's a laxative sachet. So these 8 medication actually it was written in the question itself. These 8 medications. So actually, when you go in the station, what you will take, what you will do, you will just have to take a bit of history. How you're feeling now. For example, how's the fracture now? If there is any problem, any pain, any swelling, any fever, flu-like symptom, because patient had this urosepsis as well. So make sure you completely ask about all these things. Make sure patient is fine. Patient safety first thing. So ask about the patient, how you feeling now, any problem at all, any fever, flu-like symptom, any pain, any swelling, all those things you need to ask. So you ask about the urosepsis, you ask about the pelvic fracture, you covered everything. So after that, you need to take past medical history as well, because we are going to prescribe these 8 medication to a patient. So we have to make sure patient is not having any other medical condition, and patient is not taking any other medication, and patient is not allergic to anything. So these things we have to ask in past medical history. So please do ask these questions in the past medical history, and then we'll explain all these medication to a patient. And This patient, in the question it was mentioned, this lisinopril was 10 mg, but now we have changed it to 5 mg. And this patient is saying, this patient will tell you, doctor, actually I was feeling dizzy. And that was the reason actually they reduced the dose of this lisinopril to 5 mg from 10 mg. This task is very easy. You just have to explain these 8 medications. Some of the medication, for example, atorvastatin, when you're trying to explain, patient will say, doctor, actually I know about this medication, so leave it. When you explain amoxicillin, I know about this medication, so don't explain. So patient will help you, and she just want to know about only some particular medication, and whatever is written, we can just simply you can explain. Very easy. Like we had some task like asthma discharge medication, we have warfarin, so it's the same kind of that station. You just have to explain the medication, but again make sure all the station have got some history. So in this station also you have some history. You need to ask about the past medical history. You need to ask about the patient current situation, how's patient now. So do not miss that part of the thing. Yeah. So this chart, look at this chart. Because it was mentioned like alendronate main. What is that? So they are using this kind of stuff here. Yeah. So make sure we not make any mistake. This is, if you can see, AC is like before meals, PC is after food, OD, QD. See, it is QD, it is not QID. QID or QDS is something different. If they mention OD or if they mention QD, it means omni-die. That is Latin term, but every day, it means every day. Yeah. So BD, we know it's twice daily. BID is also twice daily. TDS 3 times. TID or TDS. TID is 3 times. So make sure TDS 3 times, they can give TID as well. And QDS, that is to be taken 4 times daily. And Nocte, main. Have you seen this Nocte, NOCTE or main? That was written in the question. So we should know the Latin terminology as well. And the question was written alendronate main. I was also confused when I saw this main. What is that? Then when we found it's main means every morning. And we know alendronate we have to take in the morning itself. Yeah. So main, morning. They might give something like knock. So we should know knock means night, main means morning. Yeah. PRN is as required, pro re nata, PO orally, PR rectally. Yeah. So all these things, just make sure you read these abbreviations nicely. Yeah. Because in the station, now they just mentioned about main. We don't know, tomorrow or day after, whenever your exam, they might introduce something new as well. So it's always better if you know this. And also one more thing, don't get panicked in the exam. If you see something like this and you don't know, you will get your BNF beside you. So if you open the index at the back, you will see all these things. Yeah. So it is not a big thing. If you don't know what is this, don't worry, don't panic. Open the BNF, just excuse the patient, open the BNF, and the back in the index actually, you will see everything. All these abbreviation, lating, meaning, everything you will be able to see, and you can explain it to the patient. Yeah. So there is no harm in opening the BNF. If you get a new station, if you're not sure what is main, what is not, what is that. So instead of giving any wrong information to the patient, please look at the BNF and then you'll be fine. Yeah. But yes, this time they mentioned about this main. Yeah. Every morning. Fine. And we know actually alendronate we usually give in the morning, yeah, 30. I mean, we tell the patient just to sit straight, take it with 1 glass of water, and don't lie down after taking it. So all these things you can explain. So how to explain the medication? First of all, ask the patient which medication she wants to know about, because she has been taking some of the medication before also. So maybe she's not interested in knowing those medications. Only few medications she wants to know. So explain those medication to her. Yeah, that will be good. And yes, and make sure explain the medication means explain everything. This medication, what is the function of this medication, and what is the route that you have to take, when you have to take, and how long you have to take, and what is the frequency that you have to take, what are the side effects of this medication, and the treatment of those side effects as well. Everything you need to explain about that medication. Yeah, everything. Because why we are telling the treatment of side effect as well? Because if you will not tell the treatment of side effect, patient will be thinking, oh my God, this medication has got a lot of side effect. Why should I take this medication? So that is why we are telling the management of those side effects as well. Yeah. So this all these things, this PPT, as I already mentioned, that you can download from the handouts. If you can just see that link, handouts link, you can download that. PPT stuff from that handouts. Yeah, and that handouts is password protected. You will get an email from our side after 1 hour. The password and all the details you can see in that email. So you'll be open. You will be able to open that PPTs. Yeah, you will be able to open that file and you can see this PPT and you can read it. It will be easy for you to do these stations. Yeah, so you can download this. Till 24 weeks of gestation that is legal. In some of the countries it's 20, some of the countries something else. In UK it is 24 weeks. So before 24 weeks, he or she can terminate the pregnancy. But now the question comes. There is a lot of things comes. She's asking, can I determine the sex of the child? Yes, definitely yes. At 12 to 20 weeks you can. And the next question she's asking, if it is a girl child, can I terminate the pregnancy? We are saying termination of pregnancy is okay till 24 weeks. And now she's asking very valid question. Can I terminate the pregnancy if it's a girl child? Because I know now it's a girl. For example, after 12, 14, 16 weeks, I know it's a female, it's a girl child. And you said I can terminate before 24. So can I terminate now? Can I terminate my pregnancy at this time? The answer is actually, it's strictly no. You can of sex determination that she wants a male child, its answer is no. You cannot terminate pregnancy because the child is a female. You cannot terminate. Yeah, so that is the thing that you have to make sure that you will mention here. Yeah, so she's asking these questions. She can determine the sex of the child. Yes, definitely. How? By doing ultrasound. Can I terminate the pregnancy on the basis of this girl as a girl child? No, not at all. Yeah, there had been a lot of campaigns for this selective sex determination and the termination if they want, but still it is illegal. It is legal in a lot of countries, but in UK it is illegal to terminate a child on the basis of grounds this sex counts. But again, if you will go in detail of it, they say like if there is any problem. For example, this thing is giving a lot of mental stress to the patient that this female child is giving a lot of mental pressure to the patient. Maybe like it can be done, but in that case, we have to do full psychiatric assessment of the patient or the female. Then only we'll consider. It's not very easy thing, and only you cannot. And one consultant, they usually don't take the decision actually. Two consultants, they usually sign the stuff. Like when there are two consultants, then they say, okay, we can terminate the pregnancy. So we need consent from two doctors, two consultants before we terminate the pregnancy. If one consultant sometime, because of their religion, actually, it happens in UK because a lot the thing is in this station, when we enter into the station, the nurse is saying, doctor, I don't know what happened to this patient, please have a look. So when you will look at the patient, there is nothing. When you ask like hello, no response, you can tap on the shoulder as well, no response, you can check airway breathing, there is no response. Patient is dead, no airway, no breathing, no circulation, nothing at all. So we assess like airway breathing, circulation, there was nothing actually, patient was dead. So now the thing is, now the question arises is that next thing that we should do is CPR. Let's start with the CPR. Let's see if we can do something. Yeah. So before you do CPR, patient is 93. So make sure with the nurse make sure with the nurse if patient had signed any DNAR form. In this case, yes, nurse will tell you, doctor, yes, the patient had made her wishes, made his wishes clear that he doesn't want any chest compression, doesn't want any resuscitation. So in this case, what we will do, we don't have to do anything. We have to do nothing actually. But make sure before you start CPR, you don't have to start CPR. Please ask the nurse. You can directly ask the nurse, like if there is any DNAR. There is no harm in asking directly if there is any DNAR, because patient is old. Patient has lung cancer. So definitely there are 99% of chances that that you will get DNAR form in the file. So before you start CPR, I mean, in any of the cases when you start working, before we start CPR in an old patient like this, so you should know actually, in any of the patient actually, you should know if there is any form like DNAR form or not. So in this case, the nurse is saying, yes, yes, doctor, I have this DNAR form. Yeah. So after you have the DNAR form, you are not going to do any chest compression or resuscitation, but you need to confirm the death of the patient, because there were no monitor actually. There was no monitor in the cubicle, so you don't know about anything. So you can attach the patient to the monitor. Maybe you can take an ECG, but two things you have to do to confirm the death of the patient. Take the stethoscope, listen heart and lungs. There you will hear nothing, and you have a pen torch also inside the cubicle. So take the pen torch, look at the pupils are dilated. So what you have to do is you have to, I mean, you will get two things in the cubicle. One is stethoscope, the other one is pen torch. Stethoscope and pen torch. So stethoscope, please just listen the heart and lung sound. You will hear nothing at all. And with the help of pen torch, what you're supposed to do, just look for the pupils, and pupils are dilated. As you know, patient is dead now actually. So these things you have to do. This is how you will confirm the death of the patient. How we confirm? By stethoscope and pen torch. Yeah. After that, you can ask the patient, not the patient, sorry. You can ask the nurse, like if any relatives is nearby, any family or any friends, so we can disclose the news to them. If she says yes, then we can tell her that in this case now we have to talk to the relative of the patient, and we can contact the family. Yeah. And if she's saying no, no one is there, then you can ask if she's having any contacts, any contact number or something. In that case, you can tell her like we should inform the family or friends, and definitely just mention that we will be that inform our seniors as well. I will inform our senior that this patient is no more now. Yeah. So that's the only thing we have to do in this station. There's nothing much in this station. So there are some medical notes. You just have to fill those notes actually, that you have confirmed the death of the patient, and we have to contact the family, you have to contact and inform the senior. Everything you have to fill in that form. This is actually a DNAR form. You can find it online as well, and you can see this PPT as well. So this is how it looks like. This DNAR form, name, address, date of birth, NHS number will be written here, and summary of clinical problems. First of all, patient has the capacity or not. Yes. So summary of the main clinical problem and all those things. If it has been communicated with the relatives or friends, everything will be there in this DNAR form. So what you need to do in this case actually, you need to then to write the medical notes. So there's just a plain paper where you have to write the medical notes, and on the top there was something like name, address, and all these things you just have to fill in the form, and just write a bit history about the patient and confirm the death. Just write pupils are dilated, and on chest there was no sound, heart sound, no sound, nothing at all. Contact family and inform seniors. This is just write in that, and tell the nurse as well. In this station, the name of the nurse was actually Alex. So you can tell her like actually. Just one thing: don't start CPR before seeing the DNAR. That's the only thing. Otherwise, there's nothing much in this station. Let's go for the next station. Vitamin B12 deficiency. They started asking the station also. It's a very easy station actually. Let's read the station. You are in GP. Patient is Sharon. She's 40. Came to the hospital with the tiredness. Again tiredness. See, again tiredness. What they want? They want us to rule out a lot of DDs for tiredness. Yeah, we will rule out. She has been to the GP and he did some test. Hemoglobin was found low and she was given folic acid. Folic acid, fine. She again presented with the same symptom and blood tests were repeated and vitamin B12 level were found low. Talk to her and address her concern. The thing is that the station is very easy actually because they have already mentioned in the station, in the question itself, that patient vitamin B12 levels are low. Yeah. All right. So first of all, as we have already discussed, what are the differential for tiredness? So again, once more we can read the cancer, the hypothyroid. I'm sorry again, it's hypothyroid, anemia, IBD, CKD, drug-induced depression. All those things they are the reason for tiredness. Again, ask weight loss or weight gain or weight change. I mean, any appetite problem, any anemia like tiredness or tiredness already there. Any heart racing, palpitation, dizziness, IBD like any diarrhea or blood in stool, any swelling in your legs for CKD. If patient is using any drugs like antipsychotics, SRI, and depression. How's the mood of the patient? All these things just mentioned. Yeah, just take the history. One more thing, if you know, like if patient is on vegan diet, they tend to have vitamin B12 deficiency. Actually, we rule out this stuff in a lot of station. In this station, patient is telling the doctor, I am on vegan diet for last 2 years. I was absolutely fine before that. And these symptoms started a few months back. And from last 2 years, I'm on vegan diet. That is a very, very important finding that you will get in this station. Very, very important finding that you will get in this station. So first of all, when you're taking history, one common mistake that some candidates tend to make in this, what happens is once they have seen this vitamin B12 deficiency in the question, they just concentrate on vitamin B12. They don't look for any other differential. But no, when you're doing the station, any station, you need to make sure you're ruling out all the differential. Don't only concentrate on vitamin B12. We know it is vitamin B12 deficiency, but it can be something else as well. So make sure rule out other differential as well. Don't think in a narrow area. Think broad. Try to rule out other stuff as well. Rule out other differential. Very, very important. And the finding actually we're getting here, a patient is taking vegan diet because the treatment of vitamin B12 deficiency will differ if it is diet related or if it is not dietary related. Yeah, it can be because of pernicious anemia as well. We will check that also. We'll check for pernicious anemia, intrinsic factor as well. But if it is not because of intrinsic factor, if it is vitamin B12 deficiency, so it is of two types. It might be diet related, might be non-dietary related. Let's have a look. The treatment. Treatment is diet related or not non-diet related. If it is diet related, see, we have to give an injection of hydroxycobalamin, that is 3 times per week. So it's like alternate day give for 2 weeks. So for 2 weeks, injection hydroxycobalamin, alternate day, 3 days per week. And now come here. See, for non-diet related, it's also the same. It is also injection hydroxycobalamin 3 times per week for 2 weeks. So first 2 weeks doesn't matter if it is dietary related or non-dietary related. It doesn't matter. It doesn't matter. What's the reason? What we have to do is we have to give injection, that is hydroxycobalamin. It is 3 times or alternate day, 3 times per week. Yeah, and it is for 2 weeks we have to give. Now we have to see if it is dietary related or it is non-dietary related. Because if it is dietary related, patient will be, we have to give continuous supply of vitamin B12 because patient is on vegan diet and it's a bit difficult for him or her to get vitamin B12. But yes, there are a lot of stuff available in the market. They are fortified with the vitamin B12. Yeah, you can tell them to buy those stuff. You can tell, even like we'll refer you to our colleague dietitian. They can tell you what you can take, what you can eat. Yeah, definitely you can mention those things. No problem at all. But if patient is having vitamin B12 deficiency, that is because of diet. So first is injection hydroxycobalamin 3 times per week for 2 weeks, and after that, tablet vitamin B12. We have to give him tablet, that is cyanocobalamin. It is daily. Patient has to take it daily. We have to give the supply of vitamin B12 daily as a tablet after 2 weeks. And it's not for, it's an injection hydroxycobalamin. It is twice per year. So every 6 months we will be giving this injection hydroxycobalamin, and we have to give this tablet. It is continuously daily. Yeah. So all these things, it's not like we're just giving this stuff. We will keep an eye on the level of vitamin B12 as well at the same time. Yeah. We'll keep an eye on the vitamin B12 level as well. We will be doing the repeated test for this vitamin B12. Now, if it is non-dietary related, the starting point is the same like injection, that is hydroxycobalamin 3 times per week for 2 weeks. After that, it is injection hydroxycobalamin every 3 months. Every 3 months, you have to give hydroxycobalamin injection. So the difference is, it is non-dietary related. Yeah, so it's non-dietary related. So there is no point of giving daily a tablet of cyanocobalamin. Yeah. If it is dietary related, yes, we have to give tablets daily and injection twice per year. Here it is injection every 3 months. So it is like 4 times in a year. But if it is diet related, it is 2 times per year. So that is the difference. And yeah, and in the station, make sure one thing, very important thing, patient was having folic acid problem as well. Yeah. So before taking folic acid, please check vitamin B12 as well, because if patient is having any symptom, and if we are treating the patient with this, for example, with the folic acid only, we are not checking vitamin B12. We are just checking folic acid, and we're just giving the treatment of folic acid. What will happen? Patient might improve, but patient will have maybe neurological damage, neurological damage. A lot of problem patient will be having. So make sure when you are having any folic acid deficiency, before taking folic acid, please check vitamin B12. Otherwise, it can mask the finding for vitamin B12. So before taking folic acid, please do check, tell the patient that we will check vitamin B12, very important. And the treatment here is very easy. If you just follow this table, it's very easy for you. Diet related, non-diet related. In our case, our scenario in the exam, it is actually diet related, because patient is saying I'm on vegan diet. So if patient is on vegan diet, so it is diet related. First is injection, and then we can supplement with the tablets. And before taking folic acid, please check vitamin B12. Otherwise, you'll mask the findings. Yeah, and that we don't want. All right. Thank you. Thank you so much. So we covered actually 12 stations, and all these stations are recently asked, and they are repeating these stations now. So hopefully you will see at least 2, 3, or maybe 4 stations in your exam. In your exam, if you are giving in next 1 month, you will definitely see, out of these 12, you will definitely see 2, 3, or maybe 4 stations. So do not miss. Hopefully this session was informative. and if you can post something on your on Facebook or any other major social group, it will be helpful for us. If you have any doubt, please do ask, and please download these handouts. Yeah, you can download only now. Once the webinar finish, you cannot download it. Yeah, and it is password protected. I'll send you the password in the mail. You will receive a mail 1 hour after this webinar. So if you have any doubt, you have our email, you have our WhatsApp, you have our Facebook group. Please join our Facebook group if you need any information, and if you want to see any examination video, we have kept all the examination video and mannequin also, mostly all I would say. You can just go on our YouTube channel and the Facebook group. Yeah, so you will get all the information. All right, so let me have a look at the questions that you people have asked. So I'll try to answer some of them. Yeah. And also one more thing I would like to tell, we have started a small, online course as well. It's a 5 days course. In that also, we try to cover, actually we cover everything, all the scenarios of Plab2. But if it's a 5 days, it will be a bit hectic, it will be a bit fast. So yes, so it's a 5 days course, and the next one is from 25th till 25th to 29th of July. All right, and all those students, those who will join online course, they can come to the academy, they can practice, and they will also, online people also, they will receive all the material, the latest material in by the email. So when we'll be doing the session, the 5-day session, so they can read the stuff beforehand, and it will be easy for them to listen and to follow up actually during the sessions. So 5-day session is actually for those people, those who cannot manage like 12 days. Again, I'm saying it's always advisable to attend 12 days. So you'll be getting chance to practice with the tutors, practice with the tutors, I mean, and 5 days is only for those who can't manage those 12 days. Yeah. And also you can, after attending online course, you can always join 12 days course by paying extra amount, whatever is left. Yeah. So a lot of students, they're asking like, they are joining online first and then they are coming for 12 days session. It's really helpful because they can cover lots of stuff like very easily. Yeah. And as I already mentioned, you will get full material after you book any online course or something. Yeah. So the first question is how much. Hello, the PDF file for the new scenario is asking what a password. I will send you the password. You'll get a follow-up email. You'll get the password there. No problem. In 1 hour, you'll get the password. First of all, thank you. I downloaded the PDF that you guys have uploaded, but yeah, password I'll send. No worries about password. Don't worry. You'll get the password in the follow-up email. Okay, thank you, Shiroz. I had no audio, we can't hear. All right. Okay. Have you got any handouts? So please download these handouts now, because after the webinar will finish, you will not be able to download these handouts. These PDF handouts are done as password. A password you will get, don't worry. I can't see literature review PowerPoint notes on my. Okay. Password you will get, don't worry. Yes, it's password protected. Okay, so I'm at. Why depression history is important? Yeah, I think you're asking about that station, the acne one, because see, if it's a female, young female, and actually she was really worried about these acne, and these patients can go into depression. So ask about the mood and all. They might get irritated because of this acne. Because if a patient is having acne, they feel, they don't feel like going out with their friends, with their peers. So that's the thing. It's always better to make sure, take social history and make sure you rule out the stuff. Dr. Ankur, you are going a bit too fast. Dr. Jide. Yeah, the thing is, we have to cover, like, for example, it's 12 stations, this 2-hour session, so that's why going a bit fast. Don't worry. Looking forward to meet you in the class, yeah? So don't worry, in the class, we will not be that fast. We'll be slow. We'll go with your speed. Don't worry at all. How many stations? We did the 12 stations today. How to record the webinar? Please don't record it. Password you will get. Okay. Codeine means codeine PRN. What does PRN? PRN is actually Latin term. It's pro rata. It means if necessary. It means when required. Please, can one ask the patient or DNA CPR if the patient doesn't bring? See, the thing is, you don't have to bring it up. The thing is, patient. It's always better if patient will bring it up. The thing is, in all the station, I will say, try to convince the patient to take the medication. I know we are convincing, you're not forcing. So I would say spend your 8 minutes in convincing the patient to take the medication. That would be the good thing. That's it. Yeah. Thank you. All right. All right. Will you teach everything in 5 days course? Yes, I'll teach everything. We'll teach everything in those 5 days course. Yeah. So 3 days actually is examination mannequin. So we'll finish like say 5, 6, and then 2 hours again for the session. We will cover every single thing in 5 days session. Every single thing. Don't worry. Will the patient be advised to stop vegan diet? No, you cannot see. You cannot force anyone to change anything. You can tell this is one of the reasons. I mean, I know you're talking about vitamin B12 deficiency station. You cannot tell the patient stop vegan diet. No, you can continue. You can tell the patient this is one of the reasons that you're having vitamin B12 deficiency. So it is her wish if she wants to continue with the vegan diet or not. But you can give her some options. You can tell her, like, we can refer you to a dietitian and they can tell you like which food actually you can take, because they have something like vitamin B12 in there. Because there are a lot of foods available in the market which are fortified with vitamin B12. All right. So that is the thing. But you cannot tell, but you can tell the patient this is one of the reason. You cannot tell to stop vegan diet. In the dead zone, how do we get marked for data gathering? See, there are a lot of examination stations, purely like, for example, primary survey and all. There is not much data gathering, but we are checking the airway, we are checking the breathing circulation in the beginning. We are asking the nurse about the station, the patient. When you enter into the station, you don't know anything about the patient. What you will ask, you'll take a bit of history from the from the nurse, like what happened to the patient. And she's saying, I don't know if the patient is lung cancer station and is not breathing, something like that. A bit of history is there. So you will get the marks for data gathering as well. So don't worry. What about examination? What do you mean? I didn't get this question. What about examination? If it is about online, our online course, in our online course, we cover everything. If you recorded this session, can you send it through email? Sorry, we haven't recorded, and I'm trying to download handout, but it couldn't. You can easily download, man. It's available in handouts. You can download it because that was the only option we had for this. Otherwise, I mean, we cannot send this directly. We can only put it in handouts. Is it right to address our patient by Mrs. or Mr.? Yes, but make sure patient is Miss or Mrs. Don't make mistake. Yeah. And I would tell one thing, Mr. will go with the second name. For example, the name of the patient is Peter Smith. You can say Mr. Smith. You cannot say Mr. Peter. So it is Peter or Mr. Smith. All right. Dr. Ankar, we got registered in 12 days. So 5 days is free for us, right? Yes, definitely, man. Definitely. So don't worry about it. You don't have to pay for that. The students, those who are registered for our 12 days course, they will receive an email to join online course 1 or 2 days before the course starts. Don't worry. They just click it and join it. We have to confirm that we will confirm the booking. So don't have to worry. You will get an email to join. Yeah. Before 25th of July. You'll get 1 or 2 days in advance. Just have to join. So you don't have to worry about it. After July online course, what's the next term? It will be there with our all courses. I mean, for example, the next course starting from in August. So accordingly, we will decide 5 days in between those courses, but it will be every month. Can you do a 1-2 days course with just new station? I think I have done most of the new stations. It's like 12 stations. I think we have covered most of the stuff. Yeah. All right. Next is I will be joining the online course. Yeah, looking forward to meet you. I don't have the PDF. You can download it actually from the handouts. Thank you. Regarding sex determination, could you please clear if all 3 daughters are fine, then we can help her in sex determination? Yes, I mean, if anything is related to the genetics, of female, then all the females may be having some problem. Yeah. So in this station, she's saying all my daughters are absolutely fine. They don't have any problem at all. I just want a female child because my husband wants to have a male child. That's the only thing. So don't worry. How can I get it? It's there. I mean, Dr. Jide JJ, you can get this PDF in handouts. Yeah. Do we need to attach the monitor in dead cement? No, actually, it's not that much required, because if you have pen torch and stethoscope, you can tell it is dead. You can confirm. Thank you. In sex determination, can we give option of adoption? We can give the option of adoption, but it depends. I mean, if the question is she is asking about male child, but yeah, you can always give option for that. Thank you. Thank you. But PDF file, actually, most of the students they have downloaded. I think there is some problem with. You can try it again, please. Please try to download. It's there in the handouts. Just one question: do we give dietary advice in vitamin B12 station? Yes. See, we will give the vitamin B12 in that patient. We will give, because you just tell, like, we will refer you to the dietitian, because she's on vegan diet, so you cannot tell the patient to eat this, to eat that thing, yeah, because she will not be ready to listen to you, because she's on vegan diet, so we cannot say that. But let me see. Actually, the good source for vitamin B12 won't be good for her, but there are some fortified breakfasts that you can get, and also there are some yeast extract, like the thing is marmite. Actually, it was written on the NHS website. They have got vitamin B12 deficient, vitamin B12 content, and these are good for the patient, those who are on vegan diet. Yeah, so that can be we can mention those things. So dietary advice is like, we have to say, like, we are taking vegan food. That is one of the causes. So if you are if you want to continue the vegan diet, then we will refer to the dietitian, so they can tell you something like what you can include in your diet. Like, there's some fortified food, fortified breakfast, so she can have that thing in the diet list and she'll be fine. Yeah. Yeah, so on the top, if you are on a mobile phone, actually on the top there is an option. You can just click on that and the PDF it will appear there, and you can download. How do I locate the handouts? Actually, when you on the webinar, there are 4 or 5 options you can see on the top, and if you click one of them, try to click, and you will get one. Yeah, and this PDF you can easily download. How do I ask for ruling out Lyme's disease? Yeah, you can ask for any insect bite or any tick bite. This is how you can rule out. But the sex determination station has no notes in the PDF. The thing is, we have sent only the PDF of this. What do you say? Yeah, it's a PDF of PowerPoint actually. So whatever we discuss in this PowerPoint, so PDF is a PowerPoint PDF, so you can have that. Can we join the online class starting on 25th? Yeah, Dr. Suleiman, yeah, you were in the previous batch. No worry, definitely you will get access. Thank you so much. Can't see the PDF. It's there, man. Should we ask to see a DNR form to the nurse? Yes, definitely. Or should we assume it's there? No, you cannot assume. How you can assume the DNR form is there? You have to ask. I mean, if there are notes on the table, you can go through the notes, because patient 23 and patient is having this lung cancer and all those stuff. Before you approach to the patient, you should have a bit of knowledge about the patient. We cannot just directly go to the patient. Yeah. So ask the nurse. Thank you so much. Thank you. How much does the online course cost, or is it free? It's not free. It is. You can go on our website. It's there. www.aspiretoplab.com. It's just written some here. So you will get all the information about our Plab2 course and about our online course below. Do we need to ask about the sexual history in a rash patient? Yes, please take the rash history. Definitely. You can rule out syphilis. One of the very important ones. Definitely. Yeah. Assessor and circular from antidepressants. All right. Fine. Thank you. Are you people planning any session in India next few months? Yes, our next session, live session in India will be in January. We will tell you the dates soon. All right, all right. Thank you so much. In a dead scene, man, what's the worst word to say? First word, sorry, it was the first word to say. Will I introduce myself? Yes, of course. See, when you'll go in these kind of station, we have that primary survey, unconscious as well. In those stations also, we go and talk to the nurse first. We introduce ourselves to the nurse first. Yeah. Do we have to open the BNF for prescribing medication station for each tablet? See, if you know which medication you're going to prescribe, there's no need to open BNF. If you know it, no need to open. If you don't know anything about that particular medicine or something, open the BNF. As simple as that. Thank you, thank you, Toyn. Very explained. Thank you. What are the numbers of differential we should rule it out in? See, it depends. It depends. You should not go beyond 3 or 4 because the way they give the history, they made it sure like it's that diagnosis. So don't rule out so many differential. That if you ruling out too many differential, it gives an impression that you're not a doctor, you're a medical student. That's why you're trying to rule out like 10 differential or something. So try to rule out only 3, 4, but make sure those 3, 4 are emergencies. They are red flags. Can we get a breakdown of the topics that will be covered in each day? I think you're talking about the online session. Yes, we will tell that. Don't worry. Thanks for the webinar. Is the information presented in the same day in? Is the information presented in the same day in 12 days prep, or is it more detailed? Of course, it will be detailed, man. This I did in 2 hours, and that will be 8 to 10 hours daily for 12 days. It will be detailed stuff, definitely. Thank you, Ali. Where I can find the handouts, you can find out. In vitamin D, they mentioned that patient has been running investigation for the tiredness for 2 months, and finally the results came vitamin deficiency. Why should I ask about differential if already they excluded it by all the tests? I think it's kind of station where they want us to discuss the result with the patient. Yes, they want us to discuss the result. They want us to give the management of vitamin B12. And it's always good if you will rule out some red flags. All right, you will get some marks for data gathering as well. If it is diagnosed a counseling station, if the diagnosis is given in the station, for example, in vitamin B12 deficiency, the diagnosis is given in the question itself. So it is a counseling station. But in all the counseling stations, we take a bit of history first, then we tell the patient. If you will not take history, how will you come to know that the patient is having vitamin B12 deficiency because of diet? How will you know it's diet related or non-diet related? You need to rule out some of the differential. I'm not saying rule out many. Rule out 2 or 3 which are emergencies and take past and personal history. In some conjunctival hemorrhage, shall we ask? No, you don't have to directly ask about amitriptyline. You just can say if you're taking any medication. That's it. Don't have to go for specific. What are side effects of isotretinoin? There are there's 100 of side effects. It's like it can affect the liver and kidneys and all. So we usually do blood tests for liver and kidneys with the medication. So we have to make sure the patient is not having all these things. Yeah. In fungal infection, do we get a picture of the patient? Yes, you will get the picture in this station. You will get the picture, so you'll be able to make sure it's a fungal infection, not the Lyme's disease. Thank you. On what grounds can a patient get abortion after 20 weeks of periods of gestation? It's all the grounds. The thing is, all the grounds that you might be having in your country as well. If that is creating any problem to the mother or any problem with the child, you can have abortion, no problem at all. There are hundreds of grounds you can have if you don't want, the baby or something. But mostly, if patient is saying I don't want the baby, they will come to the hospital, for example, when they are 6, 8, 10 weeks of gestation. They will not come at 24 weeks of gestation. For example, if they're having any problem, any genetic problem, that also they will get to know, for example, after 20 weeks. So in that case, that is why they have kept it as 24 weeks of gestation. Are mocks inclusive for people attending the course? Yes, our full 12 days course include 2 mocks. In the online course, all stations cover just like 12 days. Just like, see, in 12 days course, we practice with the students. So of course, in 5 days course, online course, we cannot practice, but yes, we will cover all the stations. Okay, thank you. Yes, if there is any new station, then definitely we'll conduct more station for this. How do we use the password on a website? The password, you'll get the password. What is BNF? What is BNF? Oh my gosh. It is British National Formulary. You will get the detail about the medications and all. Don't worry, Javed. Once you come here, I'll show you what is BNF. Don't worry. Are we allowed to declare death? Yes, definitely. If you have all the things, you can declare the death. But as I mentioned, we are involving our senior as well. I'm an old fan. So amazing. Old fan. I don't know that. Thank you. Thank you. Thank you. How many weeks of practice do you recommend before the exam? After the course, 3 to 4 weeks. It's advisable. Will the 5-day Plab2 course be by the webinar too? Yes, we will be using the same app. So we'll be doing all the examination mannequin. So it will be a live telecast for the class for 3 days, and in the rest of the stuff, rest of the time, we'll be covering all the stuff through the webinar. Yep. I'm yet to get the material. What about the mocks? Mocks are included in 12 days course. In Dina, do we have to ask the nurse to arrange a talk with the relatives? Yes, definitely. In unresponsive semen, do we actually need to perform CPR just as this? No, I mean, if it is DNA or CPR, if the DNAR is there, you don't have to do CPR. Just assess and declare it. What are the charges of online course? It's 200 pounds, mate. Hi, after attending the online course, can you attend the academy if I choose not opting for 12 days? Yes, you can come to the academy and practice after online course. You're most welcome. If we are a bit unsure about some contraindication, we can refer BNF. Yes, you can definitely refer BNF. And if there are many medication, can we ask for any specific contraindication for any specific? The thing is, ask the patient which medication he or she wants to know, because in this scenario, actually, out of 8 medications, she is already taking 2, 3, 4 medication, and she knows about those medications. So you don't have to tell her about those medications. How much for the 5 days course? 5 days is 200. And all vitamin B12, the vitamin B12 tablets given daily in the injection are toxic. Will it be continued in that? No, we will be actually doing the blood test. We will do the blood test and we will decide accordingly. But if patient is on vegan diet, then yes, she has to take it for lifetime. If you take the online course, is the mocks included in that package? No, the mocks are not included that, but you can take the mocks after paying, it's £50 for each mock. Do we call a nurse by her name in UK? Yes, you can call her by her name, no problem. You can call your professor also by his or her name. And do we still have to introduce ourselves to the nurse? Yes, you have to introduce yourself. Who are you? Are you a doctor or someone else? Can I do online course in August? Yes, definitely. How do we replace vitamin B? Sorry, I had a power cut. You can actually download this handouts and everything is actually available, the treatment one. Because it depends if it is dietary related or it is non-dietary related. Yeah. Timing of online course will be from 10 o'clock in the morning till 7:30 according to UK timing. We need to look at BNF. It depends on you. After attending 5 days online session, can you attend the class after paying the rest of the fees? Definitely yes. How many weeks of practice do you recommend before the 3 to 4 weeks after the course? Will you discuss the new station during the live class? Definitely yes. We will discuss all the new station in the class in today's course. Don't worry, Benjamin. Thank you. Like getting the HOTS just like the regular students there. I didn't get the question. I'm clicking on the PDF, nothing happening. We need to examine the patient after taking history or examiner that you have to mention about examination. Do you open BN for settle from side effects? Yes. If you don't know in a flu jab, how do I initially approach? Ask the patient why did she come to the hospital? What are her concerns? Her concern is about the side effect of the jab, like my son might get fever, rash, or some seizure or something. These are the questions. So take a bit of history about the son, how was the birth, the pediatric history, and then you will address all the concerns. And do we open BNF when we prescribe or say at the end I'll check. So if you are sure about that this is the right medication, only to open this BNF. If you are unsure, then open. Sir, are the MOOCs included in the online course package? Online is £200. The MOOCs are not included. You can take MOOCs by paying £50 for each extra MOOC. Do you teach in detail history, talking, and communication in your 5 days course? See, the 5 days course we will be covering all the station. We cannot teach everything in detail, but we will try to cover we try to cover everything. We will tell you in a bit of like introduction of Plab2. In the introduction, you'll be knowing how to take history, how to do the communication. You'll get an idea, and then 5 days we'll cover all this stuff. Is it by saying, how can I help you? Yes. If the task is about iron deficiency anemia, how we can treat it? Iron deficiency anemia, how we can treat it? By giving iron tablets. Can you please repeat this session? I'm sorry. Any MOOCs in August between 1st to 15? Yes, you can email us. We'll tell you. Waiting for the password. You'll get, once I finish the webinar, after 1 hour of finishing the webinar, you will get an email, a follow-up email. You will get the password. Don't worry. Thank you. When do we check? Any criteria choosing injection and nasal spray? The preference is nasal spray. We give nasal spray, but injection is like if patient is, for example, this is having egg. So if patient is allergic, so maybe we can go for injection. Or if patient is having any cough, flu, already patient is having runny nose or something, in that case. But the preferred time is this one, nasal spray. Thank you, thank you, thank you. What should be the physical exam? You should be to mention ophthalmoscopy. Yes, you can mention about general physical examination. You can mention about the ophthalmoscopy. In delayed discharge scenario, who fills incident? See, incident form, who fills doesn't matter. You can fill or your colleague can fill. Incident form is like everything will be there. Mention about that particular thing. So tell the colleague if you can fill the form. In sex determination, can we just say, sorry, there is nothing we can do if no problem with her girls? No, see, you, instead of saying no, you will tell her that you will give her the reason why you are saying this. That would be better approach. In sex, if there is no genetic issue with the daughter, should we tell the woman you cannot help her to determine the sex? Yes, you will tell, but tell her why we are saying this. That would be a better option. If there's any new examination manifestation that have come up in recent exam. There's nothing. The testicular exam and the hernia one came recently. Nothing much actually. Handouts, you can there is a link here. You can download. Password you'll get shortly. Don't worry. And we are informed that free password. Yes. Those who have. Those who are there in our previous online course, they will get access free of cost. Don't worry at all. I think all of you are in our WhatsApp group. We have already given the access. We will put that access once more there. So don't worry. You will be getting the access. No worries. Thank you. It's password protected, I know, but you will get the password. Don't worry. Next, I will be having these courses online every month. What are we looking for in sexual history in the rash patient? HIV, yes, true. Syphilis, yes. How to book online course? Go on our website, www.aspiretoplab.com. You will get the link. You can join there. Can you please show the classification of acne again? Yeah, I can show, but you can download this. You will be able to get everything. Let me show you once. Just a second. Yeah, I think you are looking for this. Thank you. Thank you. After attending 5 days, can you attend the classes face to face after paying the rest of the fees? Yes, sir. Like getting the hot seat. Yeah, that. Oh, now I got your question. Yes, yes, yes. You can join the 12 days course by paying extra. Yes, 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 definitely. What's the password? I will give you the password. Don't worry. So you cannot download. You will get the password. You can download without the password. Don't worry. You will get the password. Then you can use the board on which the question is pasted inside the cubicle as clinical notes. To yes, yes, you can use it, but make sure while you're using it, don't lose eye contact with the patient. That will be a bit awkward. In back, patient have all the findings negative, just back pain, and SLR is negative. Then what will be the diagnosis? And it will be no. See. SLR is negative, and it's a back pain. It is not intravertebral disc prolapse. It is simply maybe sprain or strain, because if it is prolapse, patient will give the history of tingling, numbness, sensation. You have to make sure patient will give you tingling, numbness, sensation. All right. Just a sec. Yeah. So if SLR is negative and all the findings are negative, is a back pain. It's not a disc prolapse. It's simply sprain or strain. So we have to make sure to take the history properly. All right. All right. I have sent the password actually. If you can see. Okay. 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 In ICD, we can't prescribe the tabs, so we tell the patient, consult my senior, prescribe the med. Is it right? Yeah. So first of all, ask the patient what treatment she's already receiving. Yeah, and you can give her the treatment for this. Like for example, you can mention about this. You can mention about like you can mention about, for example, that we can prescribe topical retinoids, we can prescribe you antibiotics and the education. Mention about because the CVS, still we are not going to prescribe tablets straight away. Is on core sufficient fasting Plab2? I mean, this very, I mean, answer this question. The thing is, people, those who can't course, always advise course. After the online course, we have free. You can come to the academy mock for 5 days. For extra for the mocks. If someone wants to take the mock without attending, we are not allowing the students to take the mocks. Are we supposed to do 12 days course practice mannequins? I mean, that will be an online course as well, but and 5 who will do, they can go to the academy to practice. If one is unable to attend the full course, then yeah, 5 days course will cover everything. We will send you the material. This is what we can do. But yes, you will have to do a lot of more effort, I would say, from your side. Thank you. Thank you. have just about 10 days to spend in the UK before my exam. What do you advise? 12, 10 days. I can't. I'll say like you can join online course and practice as much as you can. That's the only thing. This is an online course will conduct by yourself. Yes. Mostly yes, 90% of the course, but one or two more teachers will be like for a few hours, but mostly by me. I have the scenario pasted outside. Give the name of the patient already. So up to you, man. And will Amonoda class will be broadcasted? No, it's not broadcast. It's only live. If you'll come here, only then you can attend. No one got the password, mate. You will get the password soon. You will get the password. We have sent also. I have typed here, and you got it. Do we lose marks if we look into the information in the BNF? No. You cannot download the webinar. You can download the slides. How can I join WhatsApp group? Please, how often has this come out? I mean, these taking us once or twice. Please for group next webinars. We'll be doing soon one more webinar on common mistakes, what common mistakes students do. So please follow our get all the information. You can't download after this meeting. Okay, I have given the password also. It's A capital Aspire number 2 Plab London. That is password. Aspire 2 Plab London. A capital and London L capital. Yeah. I have written in the chat as well if you want to see. You will get it in the email as well. Informative. Big share will ask. Thank you again. Password is Aspire to Plab London. A capital and London L capital. Or you'll get the password. I have written also, but you have to check in the chat. Musculoskeletal pain. That's the old station, mate. Regarding accommodation, accommodation is £20. If it's shared room, 25. It is single room. Email us. You will get more information. Thank you. If we are given a patient name outside the station, do we still have to ask them the name? It's up to you. It's up to you. You can confirm. Can I confirm your name? Or you can simply say, hello, John, how are you? Up to you. Thank you. The document is opening. It's password protected. The password is Aspire to Plab London. Aspire number 2 Plab London. In this, Aspire A is capital, London L is capital. I have written in the chat as well. You can just find it out and you will get a follow-up email. In that we have written the password. So just download it. All right. So thank you. Thank you so much. Okay. So I hope you have downloaded these handouts. It will be helpful. And looking forward to meet you all in the academy, hopefully. And yeah, and the next course is starting from this 21st day after, from Saturday. And after that, it's from 9th of August. All the very best. Those who are going to appear for the exam soon, maybe next week or next 1 month or something. All the very best. You will do well. Don't worry. Relax. That is the main thing that we have to do in this exam. Relax, relax, relax. All right. If anything comes up, any new more station, we will try to do another webinar. Yeah. Aspire to Plab London. Plab, plab, plab. Um, thank you, thank you. All right, bye bye.